As we discussed, the special tests are not an alternative for imaging. Always we have to use the principle rule in and rule out. So the conditions that you're trying to identify, always you have to exclude the irrelevant causes or irrelevant diagnosis, which means if you're trying to reduce your narrow your diagnosis, always you have to use this principle. So rule in and rule out. That's the most important. And now let's get into detailed examinations. Like when you receive a patient with so for example, like if a patients have a ligament injury, so use the principle, use the reasoning process called a pattern recognitions. So always our first question should be like, did you have a fall, or where did you injure yourself? Did you have a fall, or is it a traumatic or atraumatic, or did you play? Or most of the people, they say like, I was just walking, so I slipped and then I fallen down with a rotated knee. So the ligament injuries can happen in both a traumatic as well as atraumatic injury. And so the concept called PCL before ACL, which means before you rule out that there is a ACL insufficiency, first check posterior cruciate ligaments. So because if you do a Lachman, so we just do we try to check the amount of translations of tibia in the anterior directions. So what happens, you have to hold the knee. That's a Lachman can be performed in unsupported or thigh supported or anterior drawer tibial rotations and then pivot tibial rotation. So before you check the ACL, make sure so the tibia has to be in neutral positions. So you have to push the tibia backward first, check the PCL. Is there any posterior translations? If not, then try to do a Lachman. So in order to diagnose the PCL, so you have to do a step of a Saxine or a posterior drawer. And for ACL, we do Lachman. That's been standardized examinations in the clinical practice. Then the anterior drawer signs. And so for MCL and LCL, we do check valgus and varus stress. And posterolateral cornel, you have to do a lift-off test or dial test in supine at 30 and 90 degree and then prone at 90 degree. So if you try to load the meniscal pathology, what we look for, again, we have to use the clinical reasoning process called the pattern recognitions. So where does the pain come from? So if you ask the patients, so where is the site of pain? If you ask the patients, where is your pain? So if patient says, I have a pain and discomfort on my lateral or medial side, or I have a pain during my knee bending or extending. So in order to confirm the meniscal pathology, so either we have to do a McMurray's inflection and rotations. Also we'll assess valgus and varus strain with rotations. Applies in prone, we need to check really. So whether we'll be whether does the Applies test has a good sensitivity and specificity. Thasali, still it's a question mark. So because it has to be done in a weight bearing positions. And when we talk about patellofemoral testing, is again we have to use the clinical reasoning process called pattern recognitions. So we use the pattern recognitions to exclude. So we call it as the diagnosis of exclusion. So we try to exclude what is not up to that. So once you start assessing the patellofemoral pain or dysfunctions, so we have to move the patella, the quality of the movement of a patella in a knee joint. So is it moving in all directions, or is there any restrictions in the patellar glide? And then you should check whether is there any tenderness just below the patella. And we also check, is there any tenderness in the patellar tendon or a fat pad or plica or differentiations. So and then we also need to check for a medial patellofemoral ligament and retinaculum on both sides. And then also we need to check the VMO insertions angle and Q angle, and then patellofemoral joint compressions. And we need to focus also on the kinetic chain, eccentric pattern of a eccentric pattern as well as gait pattern, the way he walks, whether the patient has got a good heel strike, foot flat mid stance, acceleration to deceleration process. And apart from that also we have to assess the functional testing, like which includes both hop, landing and vertical jump. And then if you want to test the um, muscle, we use isokinetic strength testing system to measure the strength of a muscle on both sides. And then also you can use some of the functional score for a patellofemoral. So what are the functional score that we commonly use in knee injuries? Like one International DA Documentation Committee, the lower extremity function scale, and the knee injury and osteoarthritis outcome score, that's called KOOS. And now we are going to little bit talk about patellofemoral pain syndrome. So the patellofemoral pain syndrome is defined as a condition characterized by a diffuse localized pain around the peripatellar and retropatellar region. Typically, the pain can be provoked by the activities that increase the patellofemoral joint compressive forces, such as ascending or a descending stair, squatting, and prolonged sitting with flexed knee. And no consensus on optimal management, since the source of pain may be various or a different structures. Yes, as we seen in the very first slide. So the source of pain may be a various or a different structures. We cannot say that the cause for the pain is there is no specific pain, there is no specific cause for the pain. So majority of the patellofemoral pain syndrome symptoms may be originating from the anterior synovial tissue, or it could be from retinaculum, could be from fat pad and capsule, rather than from degeneration of the patellofemoral articular surfaces. So the source of pain in the patellofemoral patients is multifactorial. I hope you all agree with the surrounding soft tissue, showing evidence of localized pain perceptions and neural adaptations that appear to contribute the source of patellofemoral pain, as discussed by Fulkes in 2004. So as a summary, no consensus on optimal management, since the source of pain, especially the patellofemoral pain syndrome, in patellofemoral pain syndrome, the source of pain may be from various or different structures, number one. So could be the patellofemoral pain symptoms may be originating from the anterior synovial tissue or retinaculum medial, either medial or lateral retinaculum, or fat pad or a capsule. And the cause for the patellofemoral pain syndrome is multifactorial. So most of the patients, when they walk into our clinic, if patient says I have a pain in my knee, we should always check, is there pain above the kneecap or just below the kneecap or on medial side to the kneecap, or is it the pain that's close to the patella or on the other side. So always you have to check the pain just above the kneecap or below the kneecap or on the lateral side or the medial side. So when you talk about patellofemoral pain syndrome, the patellofemoral pain syndrome, also named as AKP and CMP versus PFP, anterior knee pain versus chondromalacia patella versus patellofemoral pain. So here the patellofemoral pain syndrome is defined as characterized by a diffuse localized pain around the peripatellar and retropatellar region, as I said it earlier. Now So when you talk about clinical subgroups, so how do you differentiate patellar compression syndrome? Either it is excessive lateral pressure syndrome, and then how do you manage it? So the P of PS, the patellofemoral pain syndrome, has a subclinical groups. So the patellar compression syndrome, especially if you have excessive lateral pressure syndrome, and then how do you manage it? So it may be treated, it might be treated conservatively with the soft tissue mobilizations, or keeping a heat pad, or a taping can be done for a soft tissue creep. Same the patellar pressure compression syndrome. So then how do you differentiate between patellar compression as well as global patellar syndrome? So whereas if it is a global patellar pressure syndrome, so we have to start off with the non-weight bearing swim staining. Maybe you can advise hydrotherapy. You can make the patient to walk in the pool, and then especially these people has to avoid cycling, stress, and then resisted knee extension, and taping. And so when you talk about patellar instability, the patellar instability can be categorized into three. One is chronic, acute patellar dislocations, or recurrent patellar dislocations. So if it is an instability, then we have to put the patient on static brace, and then once we know from the static brace, we have to put them into dynamic activities called neuromuscular drills, neuromuscular control of patella, and then you have to teach neuromuscular control exercises for the knee, leg as a whole. You have to treat as a whole, not as an individual part. So what happens? What are the biomechanical dysfunctions? So both proximal and distally within kinetic chain, and alterations in foot and ankle mechanics, and then reduced hip strength, possibility of limb length discrepancy, and then lack of flexibility in a muscle. So what happens if it is a direct patellar trauma or soft tissue lesions? So when you talk about soft tissue lesions, plica, maybe we will be able to avoid repetitive flexions. If you find that if it is a lateral knee pain, IT band, IT band frictions, maybe you have to improve the length for IT band muscle. Of course, the IT band cannot be stretched since it's a continuation of TFL as well as glutes max. So, and if it is a fat pad, then maybe excessive quadriceps exercises. So if it is a medial patellofemoral ligament, so brace and then tape. So what happens if it is overuse syndrome like tendinitis and tendinopathy? So what we need to do, we need to do a correction of error, frictions, and then change the eccentric load. So now we are moving to an interesting chapter called ACL rehabilitation. So I hope we guys have come across a lot of patients who underwent ACL reconstructions either with STG or BTB or PTG, or sometimes even peroneus longus graft. It's a very challenging rehabilitations in the field of sports physiotherapy, because it takes minimum 6 months and maximum of a year to put the player back in field. So when you talk about ACL rehabilitations, so the anterior cruciate ligament injuries are common, and most often it's a non-contact injuries, about 60%, and then decelerations. The ACL injuries can happen during decelerations, twisting, or pivoting. And all the ACL rehabilitation is a scientific, customized, considering all the variables, and mostly it's associated with the ligamentous injuries, and the ACL injuries are most common in female athlete as high as 9:1, and then mostly operated. So ACL can be treated surgically in most of the times.